Okay. Hi, my name is Hannah Wilkinson. This is Tafe, who's one of our fellow students. This is going to be my shoulder presentation. So after taking a full subjective history and progressing on to the objective, from Tafe's history, I would just like to highlight he has had a previous grade 2 rupture to his ACJ, and therefore we have some anatomical changes on the right hand shoulder. But other than that, he has no other current injury or symptoms in any of his shoulders, and so we will get started. So I usually do assessments from standing from behind and actually use a mirror in front to look at the range of movement. I just find this saves time, and I like to have a really good understanding of the scapulothoracic rhythm throughout these movements. So this is a personal preference, so I'll run you through the assessment now. So to begin with, we're going to look at Tafe's posture. So primarily from the posterior aspect, we're looking at upper trap definition, of which Tafe has quite a lot. And we're going to be looking at infraspinatus. We've got the spine of the scapula here, so that gives us the indication that infraspinatus is located here, teres minor there. Also looking at thoracic position and into the lumbar, so he doesn't have any excessive kyphosis or lordosis, and the spine, the C-spine is in a nice neutral position. So progressing to the side, I'm looking to see if he's got any anterior rotation of the glenohumeral joint, any protraction through his scapula. In this position, however, he looks neutral. So progressing to the front, as mentioned previously, we have a slight alteration in the anatomy of the ACJ here. Sitting on the left is a little bit higher. But other than that, he looks fairly equal and neutral, no protraction through the shoulder complex. So moving on to palpation, we can palpate bilaterally across the clavicle to the ACJ, asking the patient throughout, is there any pain, any problems there, any familiar pain. Going on to the acromion on both sides and having a feel along the edge of the acromion there. Okay. Progressing posteriorly, as I said previously, using the spine of the scapula to indicate upper traps, and you can get quite nice feedback with regards to the tone and resting nature of the upper traps and standing, and similarly for infraspinatus. All the time, initially obviously we're always looking for any erythema, any swelling, any atrophy left compared to right. So that all looks fine. Before I start conducting my shoulder assessment, I'd just like to clear Tafe's neck, because we always look at clearing above and below. So Tafe, if you don't mind just having a seat for a second, please. So I'd like you now, please, just to pop your chin to your chest. Okay. And just give a little bit of overpressure there. Any pain?
No.
No, good. And looking up to the sky as far back as you can go, please. Good. Any problems there?
No.
Fantastic. Looking ear to shoulder, please. To your left. Fantastic, that's fine. And to your right. Great. And now looking over your shoulder. Brilliant. And the other way. Good. If I was concerned at all about any neurological component with regards to the cervical spine, what I could do is Sterling's test. So we'll take the cervical into extension, and then if you can just come towards me, ear to shoulder a little. And the bed is a little low here, and we just apply a downwards pressure there. Any problems reading?
No.
Fantastic. Good. Could you please have a stand up for me, and we'll progress with the shoulder assessment. So, please could you put your hands in front, thumbs facing forwards, and I'd like to take your arms over your head nice and slowly for me. And what I'm looking for here is I'm looking for bilateral scapular lateral rotation as it comes down medial with any abnormality. So we can see from there it looks fairly equal. His range of movement is full on both sides. Okay, slowly coming down there, and there's no dropping of the scapula or any winging as far as I can see. So keeping the thumbs in front, I'd like to take your arms up and over your head out to the side. Lovely, and here we're looking for any pain provocation, again, any changes in scapulothoracic rhythm or any winging, any pain or problems there, Tafe. It looks to be a little bit more hard work here on the right hand side, but otherwise all looks fine. Could you please put your elbows in at the side and externally rotate out through there? So again, we're looking at rhomboids, drawing in here, and some the external rotators, teres minor and infraspinatus. Any pain or problems there, Ted?
No.
Okay, good. Could you please take the hands back behind you? So we're looking at extension there, which all looks good. Okay, come back down, and hands behind your back, please, and bring your thumbs up as high as you can. So we're looking for equal movement there through the scapula, equal height through the thumbs. It looks a little bit tight there through the upper traps, but otherwise it looks fine. Any pain or problems?
No, it feels
Good, fantastic. Last one, could you please bring the arms across the body? Just, that's it. Okay, any problems there?
No.
Fine, fantastic. Just progressing on, I'll have a look at strength. I tend to combine this a little bit with myotomal assessment as well, just to make sure we're clearing. So, could you please put your arms out in front of you, Tafe? So this is going to test more pec major and anterior delts, but I like to clear them as well. So please pull up, Tafe. That's it. Don't let me move you. Fantastic. Any problems there?
No.
No, this is more lats, so pushing down. Any problems there? Fantastic. Arm down to the side, please. So go straighten the arms there. Brilliant. Don't let me move you. Good. If there was any issue with any rotator cuff thickness tear there, they wouldn't be able to hold their arm there at all. So during our initial assessment with the arms in abduction, they would likely let their arm fall down, so you wouldn't be able to do that test. But that's just clearing that we're able to maintain stable abduction and it doesn't cause any pain. Could you please bring your arms in at the side? Fantastic, and push out for me. Okay, so your external rotators, and looking at internal rotators, pulling in. Any problems there?
No.
Fantastic. Going into just a little bit of myotomal, so C5. Oh, sorry, Tafe. Push against me, please don't let me move you. Any pain there?
No.
Good. And wrist extension, still C5, pulling up. Any pain there?
Sorry.
Okay, good. And pull down one hand. C6. Good. And pull up towards you. Sorry, the wrist. So this movement. That's it, perfect. Good. Any problems there?
No.
Fantastic. So fingers straight. Okay, and squeeze in on my fingers there. That's great, thank you. So that's C7. Splay the fingers, please. And don't let me draw them together. T1. Any problems there?
No, that's fine.
Fantastic, that's great. So, just to clear subscap as well, I prefer actually to do this in supine, but for fear of forgetting, we're going to do it now. So, hand behind your back. Without using your elbow, can you please push your hand away? It's quite tricky for you, okay? And relax. So, I tend to find in supine position, in prone position, you can isolate a lot more what strength we have here, whereas in standing, people tend to use their elbow a lot more, which is more triceps and lat. Okay, fine. So that all looks okay. Good. I think we'll move on to some specialist tests. Sorry, I'm just going to have to move the camera. So, Tafe, do you mind please having a seat? And we're just going to, you have a seat just there, please. That should do it. I'll just pop the bit down there. Okay, I think we're ready. So, to begin special testing, I prefer to generally eradicate the possibility of having impingement, because it is a very, very common symptom. So we need to make sure that that's not present before progressing. So one of two tests are generally used for this. One of them being Neer's test. So to do this, we have the arm in extension. We turn the thumb down towards the floor. Sorry, no sneak on here with you. We're going to stabilise the scapula. Okay, and it says passively, but I believe it's a little bit more active assistedly. We're going to take the arm up towards the ceiling. Any pain there, Tafe?
That's fine.
That's fine. Good. Okay. Secondly, Hawkins-Kennedy. So I'm going to ask the patient just to to relax his arm somewhat. And I'm going to take through internal rotation through different planes with some adduction. Any problems there? Fantastic. So, clearing the ACJ, scarf test. So, stabilising the shoulders, applying the force arms to the elbow. Any problems there?
No.
One of the tests that isn't as well known, but I really like doing in this seated position, is the modified Hawkins-Kennedy, which identifies any inferior posterior capsular stiffness. It's been tested by and developed by Addington. So in order to do this, you stabilise the opposite shoulder, rest just above the elbow on your forearm. It's a completely passive test. And you take the hand through internal rotation. Now, normal range is approximately 50 degrees. Anything below that is considered positive and indicative of inferior posterior capsular stiffness. Good. So we've established there's no impingement. I'd like to progress on to clear the biceps tendon. Okay, so in order to do that, we do Speed's test. So with Tafe sat there, stabilise the shoulder. I'm going to ask him to keep a straight arm, okay, supinated position. I'm going to apply a little bit of resistance and ask him to lift his hand up just against a little bit of resistance there. Keep going, keep going, keep going, keep going. Good. And relax. Any pain there?
No, that's fine.
No? Fantastic. Good. So, we don't have any problems there, so we're going to progress on to look at the possibility of having a slap. So, there was some interesting research done by Hun, who has developed a 3-test method of excluding a slap tear. He suggests that if one of these tests is positive, you have a 15% chance of having a slap tear, whereas if 2 are positive, you have between a 35 and a 66% chance of having a slap tear, and obviously require further referral to investigate that. So the 3 tests consist of resisted supination. Okay, so we stabilise the elbow. Take, can you please turn your hand over? Keep going, keep going, keep going, keep going. Any pain there?
No.
Fantastic. Second, sulcus snap. So again, stabilising, small distraction, a medium-sized distraction to the humerus. And we're looking for any sulcus sign just under the acromion there for any instability. Okay, and last but not least, please bring your arm into some abduction. Okay, and just relax. I'm going to take the weight of his arm here, just be nice and still. And we're going to apply a distraction, an inferior distraction force to the humerus there. And we're asking any pain, problems, or feeling of instability there, or any clicking. No? Fantastic. Good. So, none of those tests are positive, which is fantastic. I'm now going to ask Tafe to have a little lie down onto the bed for me, please. Okay. So the thing I'm going to test now is anterior posterior capsule, because I actually find it's a really nice thing to do, and it's a multifunctional position in terms of testing. I'm just going to move you up a little bit so that we don't. Okay, I might just turn that forward a little bit. Okay, I hope that's going to stay. So, in terms of, sorry, I'm just going to pop this bed up so it's in a very bad position. So, testing anterior capsule, okay. Just taking the arm into abduction at 90 and then external rotation. Okay. Generally, with this movement, if the patient has some capsular tightness anteriorly, they'll complain of stiffness, and if you continue to take it further, they'll complain of pain. Posterior capsule, similarly, but opposite direction. So maintaining and rotating through there. And obviously, we're always comparing left to right. I think I've missed saying that a bit through this presentation. However, I'm always going to be comparing to the normal shoulder. So, that's anterior posture in terms of capsule. This position can also be used to, again, differentiate for a slap. So you can do your thrower's position here, and ask Tafe, please can you push on my hand? Any problems there?
Yeah.
You're looking for plain clunking or clicking. And also, if you do this movement with somebody with a slap, often they'll say, oh, that's painful. You can then do the relocation and repeat the movement, and they'll say, oh, that feels a little bit better. Similarly for your apprehension test. So very much dependent on what you found previously and their subjective history. So, that's most of the differentiating tests. However, if there was any neurological symptoms, or if you have suspicions of any neurological compromise, I'm just going to run through the tests to show them. yeah, just to make sure we've covered them. So, median nerve test to begin with. So I'm going to depress Tafe's shoulder. These are very much about sequencing. So arm in 90, I'm going to take his hand, okay? We're going to take him into supination there and extend the wrist. We're then going to externally rotate and then extend the elbow. And we're looking for tightness, pain provocation, anything there, a bit of stretching. I think we're a bit tight through there. And obviously a lot of these tests will compare left to right for normality. Okay, obviously to tension and untension that as well, I could have asked Tafe, sorry, we'll take you there again, Tafe, to move his right ear towards his shoulder. Other right. No, right ear to right shoulder, so sideways flexion. That's it, there you go. And then back up. And ask him, when he takes his ear to his shoulder, does that make it worse or does that make it better? Okay, so that's median on there. Okay, again, shoulder depression, abduction to 90. Externally rotate, pronate, okay, and then flex the elbow. It's a bit tight. Again, I'm not going to force it because that's a little bit tight. And obviously we can ask, I'm not going to ask him to, but we can ask Tafe to take his ear towards his shoulder on the right hand side. Okay? So, progressing on to the other median and radial nerve test. Tafe, can you bring this shoulder off, please, and send your feet over that opposite corner? Fantastic. So, median nerve. Just make sure you get my hands right. We're just going to depress the shoulder there. Okay. Right, still your hand there. Elbow flexion to 90, just relax. I'm going to supinate the hand. Okay. Extend at the wrist. Okay.
Yep.
Just relax. Okay, I'm not going to extend at the wrist. I'm going to extend at the elbow and then abduct. Okay, any pain, tightness there?
Just a stretch.
Just a stretch, okay. Again, we'd use the neck as a differentiation and radial. So, once again, just relax, Tafe. So, I'm going to depress the shoulder there. Okay, I'm going to go into full pronation, flexion at the fingers and wrists, extend, internally rotate at the humerus, and then into abduction. Okay? Again, provocation with the neck, check left compared to right for symptoms, and obviously normality on the unaffected side. That concludes my shoulder assessment. Thank you very much. Thank you, Tafe.